Status migrainosus is a migraine attack that lasts greater than 72 hours. There are so many different definitions. So the International Classification of Headache Disorders is what we kind of consider our headache Bible. And it's something, by the way, that anyone can have access to. If you just Google ICHD 3, because it's the third edition, you'll be able to see the entire thing, and you'll be able to see all of those scientific definitions. But each one of these things is defined differently. Typically, a migraine attack, you'll see over there, is defined with specific, qualifications regarding features of headache pain, location, associated symptoms. The duration is defined as between 4 and 72 hours. That's the definition of a migraine attack. What if it lasts longer? That's when you call that attack status migrainosus. Separately, when migraine frequency increases to the extent that you experience some degree of headache 15 or more days in a month, and the majority of those days have some features of migraine, so superimposed on something is a phenotype, a symptom like migraine. That's what we call chronic migraine. So there are many people that experience some degree of headache pain constantly. And most people with chronic migraine will have very long, very prolonged symptoms. But this is somewhat different than an individual attack lasting more than 72 hours. There are also other kinds of headache conditions and headache diagnoses that can be chronic and can be near daily. Those also have their own unique definitions. There's something you may have heard about called NDPH, or new daily persistent headache, where a headache starts on one day and continues and continues and continues. We do consider that something different than status migrainosus.
Yeah, that was great. I mean, and you just led straight into the next question. So in fact, we're going to jump straight to question 3. Is it normal to get different or worse symptoms with status migrainosus? And this is such a great topic for me because, as you know, I've had this migraine that just hasn't stopped the past few weeks. And so it's a really pertinent question, but we also see a lot of people in our groups who ask this. So, this is my question, and the question I had was from some others as well. Is it possible to get extra blurry vision, dizziness, swollen eyes, nausea, sweats, all those kind of fun extra symptoms you wouldn't necessarily get during a shorter migraine attack, or you might, but you just may not? How normal is that?
The answer really is it depends. It's not like the most fun answer in the world, but migraine often is not stereotypical. People don't always experience exactly the same kind of attack every time they experience an exacerbation of migraine. There can be different associated symptoms every time. If you're experiencing symptoms that are completely different, things that you've really never experienced at all, I would definitely say you should let your doctor know. If you're somebody who typically does not experience tearing, or you said swollen eyes, let's say, maybe the corner of your eye turning red, or, other symptoms that you wouldn't normally, notice. Maybe you're somebody who's never had an aura in your life, and now you are experiencing it, and it's, new and different. 100%. You should definitely reach out to your doctor. That being said, is it possible for a status migrainosus, episode to feel somewhat different? For sure. By definition, it's different if you're somebody who isn't typically experiencing status migrainosus. If you're somebody and your attacks have a specified kind of duration, and here this is clearly a different duration, you can already see that there's something that's a little different about this headache.
Right. No, that makes total sense. And it was also interesting you brought up about aura, because I rarely get aura, but a few years ago I got something that looked like aura. And this is one of the reasons we don't give medical advice in our groups, is that I was in a group that did give me medical advice, told me it was aura, but actually it was blood clot. And I nearly lost my sight over it. So definitely just want to reaffirm what Dr. Berk says. Please don't ask for medical advice in our groups. And if you get something that's radically different like that, make sure you talk to your doctor. It's so important. We do have some of those things also in the latest Snoop post that we made So you can look for that. But anything that's different, just please talk to your doctor about it. So the next question is, why do so many of my attacks become intractable and resistant to treatment? Is this to do with central sensitization? Are some people just more likely to have that happen? And once it starts happening, is there any hope for you to get out of that?
There's definitely hope to get out of it for sure. Different people experience status migrainosus in very different contexts. There are some patients that I have that have relatively rare episodic migraine. Maybe they'll experience a handful of migraine attacks a year, but when they happen, they're there for days and days. And there are other patients that I have that, are they very infrequently have prolonged attacks, but it does happen, sometimes. Like, we were saying before, migraine isn't always stereotypical, and sometimes migraine can definitely, without a great reason, just be a little bit more prolonged. Like sometimes it can be a little bit less severe or a little bit more severe. It can present on one side of the head or in your neck and your shoulders a little bit more, just like it can sometimes present a little differently. This can sometimes be that different presentation. That being said, if you're starting to notice that the acute medications that you're using are much less effective, that your headaches overall are becoming more prolonged, that's definitely something that you're going to want to know, or you're going to want to bring up to your, doctor. The answer might be that we need to revamp what your, acute migraine action plan is going to be. And maybe we need to kind of hit it hard and fast earlier. And sometimes that's the answer. Sometimes the answer is, especially for somebody who always has a prolonged attack, maybe hitting it with multiple different kinds of medications that can all safely be taken together very early. One thing that we definitely, tend to see is the longer that a headache seems to, be around without being treated, oftentimes the more refractory, the more difficult it is to get that migraine overall finished. You mentioned something called central sensitization, and a lot of times that can have a role in what we call the chronification of migraine. What does this mean? What is this? Basically, if there's an area of your brain that is constantly being overloaded with signals that are saying there's pain here, there's pain here, there's pain here. A lot of times it just gets so used to it that it always thinks that there's pain even when there isn't. And that can be a reason why episodic migraine sometimes starts to become chronic, and why people start to develop other kinds of similar symptoms, something called allodynia, which is where a normal a normal touch, a soft touch or a sharp touch is actually perceived by your brain as pain, as something that's painful. That definitely sometimes can be playing a role long term.
Right, absolutely. No, those are great. And I know that you have obviously been looking at the questions that we put up there, because you are covering a lot of things that we have that we're going to be going into. And I know this is such great information for everyone. I did want to give a quick shout out for Neura Health at this point, just to let you know that one of the great things about seeing, well, I'm a big fan of you guys. So one of the great things about seeing a real headache specialist, and specifically a place like Neura Health, this is what they do, is that they don't just offer doctor's visits, but they have other things as well. So they have the health coach. We're going to be meeting with a health coach next month and showing you what this is going to be like. But they also offer, exercises for your neck, and they're accessible. So I think one of the biggest questions and one of the biggest challenges we have with people with status migrainosus is, what do you do when you're that sick and your doctor doesn't answer? And unfortunately, that's common because most headache specialist offices are overwhelmed, but Neura Health is fabulous at that. So I just encourage you, if you experience status migrainosus and you're not happy with your care, which is probably going to be a lot of you, it's worth your while giving Neura Health a try and seeing Dr. Berk or one of the other headache specialists there. So that's just a quick shout out to them. And if Lorraine or one of the other moderators could maybe put that link in the chat, that would be fabulous. And we'll also put it in afterwards. But now I want to get back to the central sensitization thing just very quickly and ask you, We have a question about comorbid conditions, and I'm wondering, the question that someone asked was, are there any other comorbid conditions that make it more likely for status migrainosus to occur? But I think I would kind of add to that, are there other chronic comorbid conditions like pain conditions that make central sensitization more likely and therefore aggravate the migraine? So what would you say to that?
I would say in general, things that can lead to more chronic, pain sensation, more, a more chronic pain status, having, more, being faced and experiencing very, frequent, pain symptoms definitely will, increase the risk for developing status migrainosus to an extent. That can be, things like just chronic migraine. We talk sometimes about, rebound, or what people call medication overuse or adaptation, headache. And sometimes if you are less successful with using acute medications, it may actually be, best to, consider changing those, because then when you start to use the same, exact medications over and over again, you could be left with a much more prolonged attack.
Yeah, absolutely. No, that makes total sense. Thank you for sharing that. We did have a quick new question I want to address. So we're just going to step back one moment. And someone's asking what they need to get started with NeuroHealth. I'm going to give from my perspective, and then maybe you can add whatever you want to add, but it's very simple. You just go to the link and you sign up. Once you are signed up, there are medical forms that you fill out. I don't believe that I was asked to upload any of my old medical documents. I just submitted a history. I actually had a history from Dr. Cowan. They have a Bon Triage system online where you can go in, you can enter your entire history. Super useful if you ever apply for disability as well. I literally cut and pasted that and put it into my medical records. So that was what I did. But other than that, what would you add for someone just to get started with NeuroHealth?
For the most part, your story, that's really what you need. And obviously, the more information that we can, that you can bring to us, the better. One of the things that you may notice is, at least for many of us, we'll say, if you had an MRI, I want to be able to see the images. I want to be able to review it. It could be that the radiologist said it was normal, but maybe we'll be able to see something subtle with regards to the CSF, or maybe spinal nerve root compression that's causing, another kind of rare, headache. Sometimes there are subtle things. So I would say, obviously, the more information that you have, the best. That being said, we're here with as much or as little information as you have. If you have your story, we'll obviously ask you an intake form, but that to me is, I would say, where I glean the vast majority of the information that I use to make a diagnosis and the treatment recommendations.
Yeah, I love that. And I didn't realize until I think it was last week when you and I talked, you said that I could send you my imaging. And that's great, because it's not like one doctor sees exactly the same as every other doctor sees. Every doctor's got different experience. And so it's fabulous that you offer that. If you do get imaging done, all I'm going to do is tell you what Dr. Berk told me, is make sure you get your CD before you leave the imaging place, so you have it, and then they will walk you through what to do with that. So thank you for that. And I think this is another thing that really makes NeuroHealth just stand out. Is so much needed in the migraine disease space. And that is why we keep pushing NeuroHealth, because there's nothing else quite like this. So a quick question here, and this is very similar to a question that we have coming on anyway, is this person says they have chronic migraine 20 days a month. And after 72 hours of an attack, they get a break for 30 minutes, then it comes back. Is it status migrainosus? We have a very similar question at the bottom. So I'm just going to do all of them at once. Someone wrote, if this migraine attack never goes away, is there anything that can help? Is it status migrainosus? Is it possible for status migrainosus to last weeks or years even? Is that something different?
Status migrainosus can definitely last weeks. The question really becomes, if it's going on well beyond that, maybe there's something else at play. it can be that an episodic migraine is slowly chronifying and becoming chronic migraine. It may be that, and this does happen sometimes, that you develop new daily persistent headaches. So you have episodic migraine and you wake up one day, a headache that starts on a specific day, and it takes a very long time before it starts to get better. It may be that there's a different condition that is going on, completely and totally. And maybe that it's, a spinal CSF leak, intracranial hypotension, where the spinal fluid, volume and pressure is low, leading to another kind of, headache that can become daily. What usually will happen is, if you are going to reach out to your doctor, what we'll first probably try to do is something to break a bad cycle. That may be a steroid, short course of an anti-inflammatory, a short course sometimes of an anti-nausea, or sometimes even like an atypical antidepressant or antipsychotic type medication that can break the cycle very, very well. And usually, if that either partially works or only some, maybe doesn't work enough, we would oftentimes actually follow it up with a second one of a different, in a different category. So if it was a steroid first, maybe an anti-nausea, or vice versa. When things continue to progress, that's where your doctor is going to say, we need to do a new set of blood tests. We probably are going to need to do new imaging. We really need to rethink this and, determine if this truly is status migrainosus or potentially something else.
Right, absolutely. And great answers there. And it kind of leads to so many questions, because if you're not seeing a certified headache specialist, or you are seeing one, but you can't get enough interaction with them during a bad attack, you just may not be being treated appropriately. I mean, if all you have is your first line abortive medications or your acute medications, and you don't have anything rescue or like you say, the atypical options or the steroids, then theoretically, I mean, correct me if I'm wrong, then a migraine could last longer than it might necessarily need to, just because you're not getting the medications you need, right?
Absolutely.
Yeah, and it's so important. So so the question is, here someone is asking, at what point should we consider steroids? And part of this question is, for me, is because I know people are going to ask this, what is the difference between prednisone, methylprednisolone, and dexamethasone? I know that you tend to prescribe dexamethasone, but what is the difference between all of these?
There are slight differences in all of these different steroids. There actually was, one study. It was a small study, but it looked head to head at, the responses for all of the different kinds of steroids that are, traditionally used. There really weren't significant differences either with regards to side effects or with regards to benefit. So oftentimes you'll see, doctors use them either interchangeably or they'll favor one. You'll see, I would say, some doctors favoring methylprednisolone, or Medrol is a kind of the brand name that you might see people use, even though it's all in generic. And you might see people use a Medrol dose pack, and it's just kind of convenient because, in this pack it'll say take this on day one, take this on day two, etc. So it's kind of simple that way. The only reason why I do tend to prescribe dexamethasone a little bit more than the others is I tend to feel that if there are any side effects, it's a little bit better tolerated than many of the other steroids. If you're going to experience anything, again, these are short-term, stints on these medications, because there can be issues with other, with taking these steroids for long periods of time. But if it's anything, it would be irritation of the stomach and insomnia. Obviously, if you're somebody who has diabetes, we would be a little bit cautious because it can elevate your glucose levels. Similarly, if you're somebody who has very high or poorly controlled blood pressure, it would also be something that we would be a little bit more cautious about doing, because it can also elevate your blood pressure. When do we want to consider it? I think was the beginning part of the question. So my apologies for not answering that.
No, it's all good. It's all good.
At the beginning. In general, I would say, if your headache is 72 hours or longer, you should be reaching out to your doctor and saying, I've had this headache for about 72 hours and I don't know right now what to do. There are, if you are somebody who has a tendency to have more prolonged migraine attacks, this may be a discussion that you actually have had,
Yeah.
even before the attack happens, and you may have already spoken to your doctor about, let's say, a stronger anti-inflammatory medication. And what the doctor might say is, once you've reached 72 hours, take this stronger anti-inflammatory medication twice a day for 5 days, or something like that. They may even give you a steroid for you to have at home, just in case this thing happens. It's good to have a rescue plan just in case.
Right.
If you're somebody who actually does quite well with your, standard acute medications, sometimes it's not necessary. But certainly if you've ended up in this situation beforehand, it's worth having a discussion with your doctor when your doctor says, okay, for prevention, you're going to do this. And for acute treatment, you're going to do that. And then you can say, what if, or
What if?
happened to me that, this hasn't worked very well. What can I do then? And that kind of opens up a discussion regarding a real acute action plan.
Right, absolutely. And that's something that we did a project on sometime around this time last year, which was our acute not our prevention plan, excuse me. It was our acute action plan that we created. And go onto our website, look in our toolbox. It's a subtitle under that. And we have a blog for every different question. It actually also includes even how you might treat different types of attacks, like an attack where that you have to be driving your children around. You may treat differently than attack, then you can just stay at home and you can lie down, or an attack with different symptoms, or an attack that you wake up with, in the middle of the night that's already been going for a while and it's full blown. So go look at that on our website, because we have a lot of resources for it. I also want to direct you to a YouTube. If Lorraine can't find that right now, then we will post it later, which we did with Dr. Berk, which was about unusual treatments, alternative and off-label treatments. So we're not going to go over that information again in this video, because we already have this amazing Facebook Live with Dr. Berk about it. So we're going to post that. So just go take a look at those resources. We had a couple of questions about steroids. So I call steroids the drug that I love to hate, because it will break an attack most of the time if I take a decent enough dose. But then by day 3, it takes 3 days to kick in. So for me, like right now, my steroids are just kicking in. So I actually put makeup on today, at least some of it. But still, feeling kind of cruddy because I didn't sleep well. So that's a side effect of steroids, is that it can cause insomnia. So, for me personally, I take extra melatonin if I need to do that, or Benadryl or something, simple that won't interact, right? See, Dr. Buck's nodding his head, so hopefully I'm not saying anything stupid here. But we do have a question here about, what if you can't take steroids? Or what if, this is another question, it doesn't break your attack? I know that for me, because I've been on steroids on and off for so many years, generally I need a higher dose than just the Medrol dose pack. So I'm sorry, that's like 2 questions together. What if you can't take steroids? And what if you take it, but they don't work? Do you need a second or a longer or a different type of steroid?
The answer, first of all, if you can't take a steroid is, why can't you take it? If the reason is because of prior GI irritation, maybe Barrett's esophagus or bad reflux, history of gastric ulcers and things like that, then you can't take an anti-inflammatory either. The answer might be taking, like we mentioned, some of the anti-nausea type medications that can be like Reglan, Compazine, Promethazine, which is Phenergan, some atypical antidepressant type medications. One that we sometimes use is one that's called olanzapine. It can be somewhat sedating, but it can be in many situations very effective in breaking a very severe cycle. There are, I would definitely say that there are some people that will use even things like muscle relaxants or gabapentin in other patients that just can't take any other kinds of medications. There are some triptans that will even sometimes use. Actually, there's a study out of the Faulkner Hospital, which is their main headache center at Brigham and Women's Hospital in Boston. and it looked at using Neura, which is the, one of the longer acting triptan medications, using that not so much for status migrainosus if you randomly experience a prolonged attack, but specifically in menstrual migraine. Status migrainosus can sometimes actually happen in some people once a month, and you can have a very prolonged and sometimes very severe attack. And what they looked at was starting a bridge dose, another term, sometimes people will call it a steroid taper. Taper implies that you're going down a dose of medication. Sometimes another word for it is a bridge. You're trying to kind of bridge the gap between a preventive and an acute medication. So you start to take this twice a day for 3 days, starting the first day of your menstrual period, or sometimes even the day prior to it, if that's when you start to notice symptoms. And the first, 2 days of it, it was shown to be very effective and not necessarily associated with, rebound medication overuse or adaptation headache. So it doesn't necessarily make your headache worse long-term. So that's theoretically another option also. If a steroid doesn't work, same answer, you could theoretically consider some of these other options. Sometimes at that point, we may even consider, depending what kinds of access we have to it, to IV medications. Some of them are very similar medications to what we've discussed, an IV, anti-inflammatory, like, it might be Toradol. It might be, an IV steroid. It might be IV Benadryl or Reglan, the anti-nausea type medication. DHE is kind of like a triptan. It's an older medication that the triptans chemically are based off of, but it can be sometimes very effective in breaking a bad, attack. So thinking about using some of these in an IV form.
Yeah, interesting. That's super interesting. And by the way, I know we have less than 10 minutes left now. So, but we're going to get into the ER very, very briefly. But before we do that, I also just wanted to add that if you see more than one specialist, so let's say you see a gastroenterologist and they tell you don't take steroids or don't take anti-inflammatories, it's always worthwhile seeing if you can connect your specialists so they can talk together. I had my one GI one time say, I told you, do not take this medicine. And I wanted to say to him, have you ever had a really severe migraine? It's just not an option for me not to. I stopped seeing him and found a much better GI who was willing to say, okay, if you had to keep taking it, these are the options that you can do. So just because one doctor says you can't do something, just explore it, and have your doctors talk to each other about what can be done, because sometimes, presumably you can't take steroids, but sometimes there are things you can take that you may need to take something else on top, which of course could result in polypharma and more complications, but it's quality of life, right? If you have very severe migraine, we're talking about quality of life. And as we all know, most of the people in my group know that quality of life can be really terrible with chronic migraine or status migrainosus. And that's important. Pain management is very, very important. So we're going to kind of move quickly onto the ER. We did do a Facebook Live about ER. I believe it was with Dr. Miles Starling, probably about 2 years ago. So maybe time to do that again, and we'll post you the link to that YouTube as well. But I think it would be a mistake not to cover this really quickly. So 72 hours is a really long time to suffer from a migraine attack. Not everybody is with Neura Health yet. Not everybody is with a doctor who understands how to treat migraine, right? The status migrainosus. So what point do you consider going to the ER?
First of all, I would say you may want to consider going to the emergency room if you've had a migraine attack that's over 72 hours and you don't have the appropriate treatment at hand. To be honest, the ER is the last place you want to be as somebody who's experiencing a severe and prolonged migraine. It's loud, it's smelly, it's bright. Oftentimes they don't take migraine very seriously.
You're a low priority when you're there with migraine, right?
Exactly. To be honest, as a neurologist, the ER is not a place where I necessarily like to hang out. No offense to any of my ER colleagues. I kind of like my office. It's very nice. It's quiet. I can control things as much as possible. And it's definitely not a place that you want to be. But it's it may be necessary. And certainly if you're experiencing some of those symptoms that we talked about before that are new or different, certainly you're going to want to go to an emergency room if the onset is very rapid, a thunderclap kind of headache, something that is, very sudden, very severe. That to me is a major red flag. That's something that I'm very, very concerned about. If there are, different symptoms that you had ever experienced before, or that's very prolonged and you've never had anything like that before, those would definitely be reasons to go to an emergency room. So if you really don't have a good plan with regards to, what to do next, you don't have somebody who could give you a good option, it's at least a place where that's possible. And the other, thing is if you need to get evaluated, if there's something that theoretically is concerning, that would be another reason to go.
Absolutely. No, that's great. Those are really great answers. The only thing that I guess I might add to that is if you're a frequent flyer in the ER, then I know back in like 2000 and I don't know, 5 to 2006, I was definitely a frequent flyer and had to change to a much better headache specialist, a very well-known one, who's also part of our medical board now. And he ended up saying, you can't live in the ER. I'm going to give you medication to use at home. And so that's part of working closely with a certified headache specialist, because as you say, the ER is not a good place for anyone. So if that's happening to you frequently, something needs to change, right? Either it's a misdiagnosis or you don't have the treatment you need, you're not seeing the right doctor. And this is where advocating for yourself comes in. And we talk about this all the time, being an empowered patient. It's not fair, but it is reality. You're going to have to advocate for yourself. And we encourage you to, again, go to our website and look at all the resources. We have a huge amount of resources on our website. And starting by the beginning of March, our website's going to be revamped, so it's easier to find everything as well. So just encourage you to take advantage of all that. Here's probably our next to last question, if not the last one. And that is, if my prescribed medications don't work within 24 hours, is there really any chance that they're going to work, or should I just try something else?
I think that there can sometimes be, the possibility that they will. For instance, depending on the medication, steroids, for instance, will sometimes take 12 or 24 hours before they actually start to do anything. So
For me, 48 hours, I would say. It's even longer.
For some people, really need to spend the time on that medication. Oftentimes, the reason why we'll say stay on, let's say, a longer acting or stronger prescription strength anti-inflammatory type medication is because on day one, it might not necessarily do anything, but on day 3, it will. So continuing to take it and chip away at the process of migraine that's happening in your head can actually, sometimes take the time on that medication. Sometimes you need to add a different medication in a different class, either together with, separate from the medication that you're on. There oftentimes isn't, a one size fits all option, not only for each individual person, but for each individual person's attack. So it may be that, it happens one way, and then maybe a few months or a year later, you get another prolonged attack, you reach out to your doctor and they tell you something totally different. And the reason why is maybe because they learned something from, how things went last time. Sometimes it may be that there is additional medications that, that there could be better options. Those, sometimes happen also. They've learned something new about how you respond to some of your preventive medications that, can make them think going about this approach differently could actually be more helpful.
That makes total sense. Yeah, that really does. Do you have time for one more short question, or do we need to go? We do? Okay, so this is one that was submitted ahead of time, so I did want to make sure that I get to it. And that is, the person wrote, I'm curious about the use of butalbital compounds, such as Furanil and Furacet. Are these effective for treating status migrainosus, or do you prefer not to use them? And is there a reason they're not more widely used?
They have no evidence for the treatment of status migrainosus. Absolutely none. They've never been effective for status migrainosus. Can they sometimes be used, I would say, as a rescue, as a very rare one time you've tried, this medication, that medication, and those haven't been helpful? Will there, be some physicians that will say, use a butalbital containing compound, then sometimes, I'd say rarely. We do try to avoid using those medications, primarily because all of the epidemiologic studies that have looked at risk factors for, developing chronic migraine in somebody who has episodic migraine, one of the things that they've shown is even infrequent use of butalbital containing medications is a risk factor. Certainly use more than once a week is a risk factor. Whether that's exactly rebound medication overuse or not, it definitely does something to your brain to make migraine that much more chronic. So that right now there are many more and better options that are available. So we do try to avoid it as much as we can.
And presumably the same would go for other opiates, is that those are absolutely a last resort. They're not something you want to go to unless you absolutely have to. And by absolutely have to, it doesn't mean what's easiest. It means seeing a headache specialist who can work through all the other options and hopefully keep you off them at least for as long as possible. So
Correct.
I really want to encourage everybody. We hear so much about status migrainosus in our groups. We want to tell you that you are not alone, that we hear what you go through, that most of the people that volunteer in the admin team, we get status migrainosus fairly frequently. We have chronic migraine, most of us. So we relate to what you're experiencing. We know how hard it is. So please, share what's going on in your life and take advantage of the videos, the resources. Please, again, go check out Neura Health. If you're not happy with your headache management, the doctor or the professional that you're seeing, it's okay to look elsewhere, and I should also say that Neura Health will work with your local doctors as well. They will talk to them. So it's not like an either or. If you need imaging, they will, work with the doctor you need to get imaging from and things like that. So it's not like you're letting go of your local doctor in order to see Neura Health. But I do just encourage you to check them out if you're not happy with your care. Status migrainosus is awful. We all know that, and we want to be there for you. And Dr. Berk, any final words do you want to say today?
Absolutely. More than anything, I just wanted to thank you for giving me the opportunity to speak, and thank you for, everyone who's watching us. Thanks, for being with us today on Migraine Meanderings. I hope you have found this helpful. And if you have any comments or questions that I haven't answered, please let us know in the comments. Migraine can be such a challenging disease to live with, and we encourage you to proactively partner with your doctors, explore options, and create a good and effective action plan that can actually help you manage your pain.
Absolutely. Thank you so much, everybody, for attending today. We wish you a good day.